Good afternoon and welcome to an enterprise approach to big data and analytics, a complimentary webinar from healthsystemcio.com sponsored by Optum. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. We encourage you to ask questions today. I think it's a great topic for questions. You can go ahead and send them in at any time in the Q&A box in the lower right-hand corner of your screen. Leave the default set to all panelists, and we'll take those later in the program. But go ahead, send them in as they occur to you. You can download the deck by using the URL on your screen. There's a shortened URL at the bottom of all slides, and I'll also send it out in the chat box. And we are recording today's event, and we'll post that to our YouTube channel just as soon as possible, usually within 2 business days. If not sooner, you'll get an email as soon as it's available. So you see how we're going to spend our time today. We're going to go about 45 minutes. First, we're going to hear from our good friend Chuck Podesta, CIO at UC Irvine Health. And then we're going to hear from Mike House, Senior Product Director with our sponsor Optum. Then we'll have our Q&A. So without further delay, I'm going to turn it over to Chuck Podesta. Chuck, thanks for joining us.
Thank you, Anthony, and thanks everyone for taking time out of your busy schedule. I'm going to definitely talk about an enterprise approach here to big data and analytics. I've got quite a few slides here, so I'm not going to explain, every single bullet on every slide, but I wanted to give you enough content where you have a nice takeaway slide deck that you can then do some of your own research and some of your own analysis, based on what's on some of these slides. Also, this is the stuff that we are working on at UC Health. So this is not the stuff I'm going to talk about is not pie in the sky or there is some futuristic aspects to it, but these are things that we are actually doing here at UCI and our approach to big data and analytics as we go forward. So I wanted to state that up front. So without further ado, let me get started and get to the next slide. So this is actually Thomas Edison, what he said in 1926, which I thought was a good lead-in. It's amazing. I mean, this is basically population health and patient engagement and all the things that we're talking about today. He predicted back in 1926. So thought it was an interesting slide. We're finally getting around to it, 90 years later. But pretty interesting that he said this. At UCI, this is really what the evolution of healthcare analytics, and this is the evolution at UCI, but I think also the evolution really across the United States in healthcare. And we all started out with spreadsheets, and then we added the data visualization to those spreadsheets, dashboards and things like that for presentation purposes. And then we created things like data marts and star schemas and kind of your standard data warehouse types of functionality using other types of data visualization tools, whether it's crystal reports or whatever your favorite flavor at the time was. But now we're moving to what I call a big data ecosystem, and you can see, and this is the work that we're doing here at UCI right now, but it's based on an enterprise data warehouse, and it includes things like predictive analytics, which I'm sure you've heard about, streaming device data, getting into more of a real-time ecosystem, as we go forward with population health. So if you look at a current environment, and this is pretty much what you're dealing with, what I'm dealing with, and what we dealt with in the past is really you've got the electronic medical record, pick your flavor. They're all pretty much the same when it comes to not designed for that high volume and velocity of data that's here today and it's coming in the future, and it doesn't handle complex operations. So it's really about caring for the individual patient as opposed to aggregating information. And then so that's where the data warehouse comes into, because it's kind of the opposite of that. It allows you to aggregate the data and start to do some analysis. But in today's world, most of that is you've got that latency factor of up to 24 hours, taking the data from the EMR, other source systems, and it's not timely, and all the analysis is really retrospective as opposed to in real time. And that was okay, but that's not going to be okay as we go forward into the future. Now, some people are actually doing real time we are here as well. But I can tell you the norm is really what this slide shows, is most people have an enterprise data warehouse that has a latency factor to it at this point. And some of that's the technology, and some of it's just, it's built, 5 years ago or 10 years ago, and they're still running it the way it's always been done in the past. So those things are changing. So if you look at kind of the current data sources that are out there right now, you've got your legacy systems. Everybody's got, interface engines with HL7 feeds, and you got EMR data, physiological monitor data, device data. All that data exists out there today. Some places are bringing it in, some places are not. I think it's rapidly moving in that direction, especially when you look at some of the real-time data, device data, physiological monitors. And we are actually doing that right now. We actually take device data in 1-minute intervals, and we're actually looking at, all the patients that over the past year that have crashed at one point during their stay, and really looking at what occurred to those patients 30 minutes before they crashed, and seeing if we could come up with any trends that allow us to predict those crashes before they actually happen. You can't do that unless you have that device data, and again, it can't be, the latency factor in this case is 1 minute, not 24 hours. You have to have that in place. So that's just one example, but you can see on the right side there's a lot of other information that's starting to come in, dealing with patient engagement information. I'll show you some of that, home monitoring, RFID type systems and hospital sensors. So you really have to have an ecosystem set up to really be able to handle this data. And this is current data that exists today, and a lot of places aren't, even capturing the current data. If you look out into the future, what's coming is a bunch of stuff. So you can see all kinds of external data. Wearables are going to be big. Certainly home devices. Social media is going to be really important to capture, because people are having conversations about your organization, and you want to participate in those conversations. GIS data, omic data, which is any type of, genomic, proteomic, pick your omic, and that's coming in. Also open data. There's so many open data sources out there now. If you go to data.gov, you'll see some really interesting data that's out there in agriculture, business, climate, consumer, healthcare, all free. You can go in and grab it, pull it in. That's really the future as well. Those types of data sources are going to grow. A lot of them are going to be free, and they need to be part of your strategy. Adverse drug events is another site for you to look at. Again, that can be linked to, and you can pull data in. And then, of course, you've got everybody's talking about the Internet of Things, telematics, which, if you think about a vehicle and a car and how automated that's getting now, and that's really around telematics and GPS systems and things like that. And with 5G wireless that's coming rapidly, the speed of this stuff is going to be tremendous going forward. So the infrastructure is getting in place to really be able to handle the real-time data as well. So if you look at some use cases, and again, these are some things that we're actually doing here. The bolded bullets are some of the stuff that we're working on right now. But when if you look at early sepsis detection, we actually have a program right now that's looking at that, because we do have the device data, we have the lab data, we have the medication data. I mean, we're getting that stuff in real time, so that we can start looking at the patients in-house and start to do some of that early detection based on algorithms that we've created, and that there's some algorithms that you can pull in that are open source as well. So we're doing a lot of work in that area. Real-time nursing unit utilization, that's going to be really important as you go forward, because of how your environment on the inpatient side is going to be rapidly changing. You're going to need to be staffing kind of in a real-time mode, which is going to be interesting. You've got the research piece, and something called clinician-aware applications, which I'll show you in a minute. Event-driven care and real-time quality monitoring. We're doing that in conjunction with our quality department right now. and setting up dashboards for them to really, monitor the patient population in real time and look for trends and things like that. So pretty interesting stuff, but it's all about, catching issues early, and especially while they're in the hospital. So a lot of this stuff is you're trying to get this stuff now. Some's related to readmission and readmission penalties and things like that, but it's just the way you want to drive care in your organization. And again, it's about lowering the cost of care too while they're in your inpatient unit. You want to make sure that when they do leave, that they don't come back at that point. So, so some of the future cases though that we are looking at right now, which is pretty interesting, is you can see. Vent dashboarding in the EMR for ventilator management. There's some work being done there. Hospital-acquired infections, analysis around that, VTE surveillance. The data exists on all this stuff. There's something called a Sensium Vital digital patch coming out. It's actually out. It's a wireless patch that you can put on a patient, and it actually will monitor their vital signs from that patch. And you can send that to really any system. It's expensive right now, so you're not going to want to patch every single patient, but in certain instances where you need to monitor somebody in real time 24/7, possibly remotely, it would work quite well for that. So there's those types of things are coming. Other things on the home devices, you can see the wireless scale, vital signs, glucose, those things are out there. You've got the Fitbits, and those things are capturing data. So again, you've got all these data sources that are going to come into your ecosystem at some point. So again, it gets back to how you're going to design that, ecosystem. So on the right side, combining phenotype data with genotype data, so that's the new research that's going on right now. So it's not just looking at genetic makeup of an individual, but how does that genetic makeup, what are some of the observational characteristics of that makeup that you can start to study and utilize so that you can create, best practices in care for those particular. So you're looking at what I call patient threat analysis, but, when a patient, based on the genotype data and the phenotype data, you can start to look at, when patients are going to, if they have a certain predisposition for a particular disease, what are some of the things that you can observe in that patient that you can catch that early enough where you can start treatment early. So if it's somebody that has a predisposition to ALS or Parkinson's or Alzheimer's or, pick any of those kind of chronic diseases, what are some of the things you can start to observe prior to them getting, having that disease, and then starting treatment much earlier than what happens today. So again, that's the patient threat analysis aspect, and I can't say it too many times. Real-time data is going to be key to doing that, and using genetics to see, when patients start to go downhill and predict that actually when in their life they may go downhill. So again, it's all about getting that getting treatment started as early as possible and getting people on a particular treatment pattern. On the next slide, we've got something I mentioned, clinician-aware applications. And again, it's really interesting, some of the stuff that's going on there. And if you think about the Amazon recommendation engine, everybody uses Amazon, and you buy something, then it recommends something else, or it tells you everybody that bought this over here also. So it starts to, they call them smart notices, starts to send this stuff out to you, and may show you things that you didn't even think you were interested in, but by pushing this data out to you, all of a sudden gets your interest. And that's the same thing. We need to do this with our EMR or applications that are around our EMRs, because a lot of EMRs may not be able to do this. So you've got to surround the EMR with other types of applications that really set you up for a real-time healthcare system. So, where's the patient's respiratory therapist, for example? Connect me now to that, so the clinician in real time can start to interact with the people that they need to interact with. EMR use patterns is very interesting because you can start to study the way physicians and clinicians are using the EMR, how long they spend to do certain things. what screens are they spending a lot of time on? What order sets are they using? There's a lot of studies out there that basically say there's only 100 to 110 order sets that are actually being used in healthcare. You may have 700 or 800 of them that you built, but really 100 to 110 are the ones that are being used. And so you can start to do analysis around that and start to then, push those smart notices out to physicians, through the EMR and give them, recommendations. They're maybe using one particular order set for a particular issue, but you can push out a smart notice that basically says, hey, you may want to think about this or think about that or think about this particular order set as well, and start to really give them real-time information to care for their patients. So call those clinician-aware applications. You're going to see a lot more of that as part of your ecosystem. And again, as I'm going through this, you can see I'm not just talking about a data warehouse here. I'm truly talking about an ecosystem that you need to create. So in progress right now, again, smart notices for patients. These are things that you can actually do now. We're working on some of this stuff. Again, you can, through your patient engagement systems, maybe you have that patient interactive types of technologies within the room, so you can, identify wellness and disease topics that are of interest to them. The patient selects those. It's based on their educational level. Again, Amazon recommendation. You say, they pick something, you push something else to them, and the last bullet in that section, you can see what patients think they are interested in may not be what they are really interested in. And so that's where the pushing of the Amazon recommendations come in, using that type of technology to really cover all bases with the particular patient and make sure that they have control over what they're looking at, but you're giving them another way to think about it as well. There's also motion sensing types of applications coming out. Facial expression using cameras. There's also voice. There's technology now where you can have a conversation with somebody, a therapist can have a conversation with somebody, and you can tell whether the patient's depressed or not just by having that conversation with them. And it has nothing to do with the question and answers. It has to do with the tone and the conversation itself. So it's pretty interesting technology that's coming out. The response to pain medication right now, you ask them, there's a 10-point scale, but there's a lot of, with facial recognition, they may say a 3, and when it's really a 6 based on the facial recognition. So there's a lot, you can start to look at anxiety, things like that. Did they get the discharge instructions? Again, they may say that they did, but their facial expression says that they didn't. And so this is all about patient engagement and making sure before they leave your organization, in this particular case on the inpatient side, that they have the tools and they understand the tools so that they can take care of themselves when they get home. So this is something that's interesting. I wanted to show you, and this type of data that's out there right now. We're actually pulling this data in and looking at this data. But this is a company called Centric Health, and they're basically what they call audience-centric marketing, and they've worked in other industries. They're just starting to come into healthcare now, but all other insurance companies, anybody that's doing marketing directly to consumers, utilize this type of data to figure out a way, what's the best way to communicate with my customer, and how do they communicate. And so this is starting to come in as part of a patient engagement. And you can see from this particular slide, and by the way, I did get permission from Central Health to use this, but you can see this happens to be a Medicaid uninsured population in New York. And it shows on the left side, social media, the frequency of, what they, how they use social media. You can say 3 or more times a day, 22% of the population, and then the hours spent per week and the type of things they were doing. So emailing was 30 minutes to under an hour was a high percentage of emailing. But if you look on the far right, 8 hours or more was texting. So that gives you an idea of this patient population. Again, and then communication methods, they prefer, in person, face-to-face. And then, you can also see the percentage on social networking sites is, pretty small at this point. So it just gives you an idea of that particular patient population. Now, if you're going to reach out to that Medicaid uninsured population and communicate the way that they want to be communicated to, this gives you an idea of the preferences going forward. Same population, how they use digital devices. So do they own a cell phone or not? That's pretty important to know. You know, is it Android? Is it iPhone? Depending on the type of apps you're creating. You know, do they download apps? So you can see that. Application activities, sent or received email, you can see that's 21%. They take photos, access the internet, you know, it's pretty basic stuff, listen to music, but it gives you all that data. And then the digital, what they call digital psychographic, which is, you know, I like to be connected to my friends and family wherever I am. So different ways that they're using the devices. So it gives you a lot of data on that particular patient population. Again, you can do that with any patient population that you're serving. And then the last one I have is, you know, what's their commuting aspect. So, you know, do they have a driver's license? Do they use the bus or they drive? You can see the breakdown of all this, what streets they're on, percentage of the population, and what, you know, routes that they use, time spent working. You know, all this data that you can start to use to really profile a patient. So you end up in a situation where you've got, you know, this patient persona that you've created. And again, this is happening in other industries. When you call an insurance company, you know, as they're talking to you about a particular insurance product, they are mining that you know, while they're doing this, and they're creating a customer persona on you. So before you even hang up the phone, they have created this type of wheel on you, and this is what we need to do in healthcare as well, is to be able to, every single patient is to be able to create this kind of patient persona, and that's really the way that we need to start treating people, and it's the way that they wanted to be treated. How we communicate to them will be based on their preferences, not ours. The data that's delivered to them will be, you know, what they want to see, not what we think they want to see, and utilizing all the technology that we have to be able to do this. So again, back to the ecosystem. This is what we're creating, not a data warehouse. So if you think about the modern, you know, healthcare data platform, what it needs to be really multi-tenant. It needs to be, you know, when you think about how we're going to set this thing up, it can't be on-premise. It can't be big iron. You know, it's going to have to be in the cloud because it's going to have many, many, many connections, data coming in from all over the place, you know, from open source public side to the data within your organization. From the cost perspective, it's going to grow. It's going to grow exponentially. So, you know, having a multi-tenant type of setup is going to cut your costs down tremendously. And you're seeing that a lot with some of the vendors that are out there now. It's, you know, multi-million dollars to set up these on-premise applications, but also when they do them off-premise in the cloud, it's not multi-tenant, so they're charging an arm and a leg on maintenance. And as you grow, as your disk-based storage grows and things like that, you're getting charged for that as well. So that's really going to be the old way. You can't set up a system to do that. So you need to be able to ingest, you know, this data from internal and external. So you need an ecosystem that can do that. It should be, you know, a platform for advanced analytics. You need to leave, in some cases, you need to have a system where you're leaving the data where it is. So genetics data, I mean, you're not going to pull in genetics data from everywhere. It's huge, huge amounts of data that you're not going to be able to store, but you want to be able to go out there in real time and grab it when you need it. Same with images. You're not going to you know, store images in your data warehouse. You want to be able to reach out and get those when you need them and pull those in. So, so you need a very robust and flexible type of data platform to be able to do that. And that's really what we're building here. And I'm not going to get the big chart here. I'm not going to go in every single piece of this, but you can see that you've got the visual layer on the top, the kind of the user interface, and there's you know, a variety of you know, both open source and products that are out there. And you can see on the left side, data repositories, the enterprise data warehouse. That's just one slice of data that's being moved around. So it's, in the old way, that EDW piece would be the, a big, a big part of, probably be in the middle of this slide, and it's very much on just the left side as just another data source, along with, you can see the other data marts that are sitting there. But the real power, in our particular case, we're using a Hadoop distributed file system, and you get your security around it, your governance, your integration, your operations. You've got some traditional sources coming in from the bottom side. On the right side is the ones that we were talking about, some of the social media, home device, genomics, all this other stuff that you need to be prepared for. You're not going to do that, by the way, with SQL. Now, you can see SQL, I have it there as, one data stream. It's still here. Yeah, it still works. But in a SQL environment, for this type of ecosystem, it's not going to be able to handle the data in real time. There's just no way in the world. So if you're looking at, one thing I would urge you, if you're looking at products that are out there, do not pick something that locks you into, a SQL type of database where they're doing manual mapping to SQL from source systems. It's really the old way. You're not going to be able to pull in these emerging and non-traditional sources and be able to do, SQL's okay for 1, 2, 3, 4 use cases, but when you do 50 use cases all at the same time, SQL runs out of gas. So I know I'm probably making a lot of, there might be some SQL people on here and making you nervous, but, and believe me, we have SQL people here at UCI, and we made them nervous when, we created this ecosystem because they start to look at their job and what they're going to do, but it's all about learning and changing and moving into more emerging technologies, and people that want to do that will definitely move forward, and the ones that don't, will go the way of the dinosaurs. So this is a takeaway for you, but this is kind of our ecosystem that we're building today. Just a little bit on the cloud issue, because it is going to be a requirement. You've got to have it. From a cost perspective, services, and I know there's issues around PHI, and everybody's nervous about that, but we've got to get past that. There are cloud computing companies out there that are HIPAA compliant. There's a couple that we're working with right now, and it's not Amazon Web Services, and everybody knows they just had a breach. But at some point, you need to move into this. Otherwise, the cost associated with your ecosystem is going to be tremendous, based on the storage issues that you're going to have. Something called FHIR that's out there, and again, I'm not going to get into this, but in RESTful API, things like this, you can go out and do some research on, but this is the way that you're going to be able to take information in real time from multiple sources, whether it's public sources, private sources, in a real-time fashion. This technology is all coming to the forefront. Some standards here that are going to be very, very helpful going forward in building your ecosystem. So it's really, I call it the public API for healthcare. Building a smart platform, again, this is all about fitting in with the physician's workflow, creating these smart apps as part of your ecosystem for the clinician. And again, it's not about the EMR or the EHR, which I think you'll start to see fade into the background more and more, and there'll be wrappers around that EMR. There'll be a lot of, what we call a smart platform, which will be a bunch of apps that the clinicians will start to use. And you can see in the first bullet there in New England Journal of Medicine, something called substitutable medical apps that are being developed. And there's a lot of them today, and I think you'll see more and more of that. And again, it's all about fitting into the physician workflow and driving into, more predictive analytics. So you want to have a single platform, cloud-based single platform, but you are pulling from many, many sources. So it is a single platform, but it also may look a little bit distributed depending on how you're pulling that information in and utilizing it. But what we built is we're doing, quality measures. We've got the operational stuff. These are, products that we're building out right now with the company that we're using, and we've machine learning, application data source. You can see real-time surveillance, predictive analytics we're doing, cohort discovery on the research side, population management, genomics we're just starting with as well. So we've got a lot of activity in building out, the products in our ecosystem right now. Some of that's been done over the last 3 months, and over the next probably 3 or 4 months, we'll have a lot of this in play. So just some of the trends, something called content analytics or suggestive analytics. And basically, physicians at this point are really ready for prescriptive analytics. They're not ready for being told what to do. But there's something called suggestive analytics that's out there where you're really making those suggestions. Again, it's about the Amazon pop-up windows where you're suggesting certain things to the clinician as to what they might do. You're not saying that they need to do it. So that's the difference between the suggestive and prescriptive, because they're not quite ready for that at this point, but maybe in the future. There's our imaging analytics coming. Again, moving the analytics out of that EMR and EDW environment. You can see from the ecosystem that we built, those technologies, the ecosystem just not fit in those technologies. I know there's a lot of the EMR vendors out there, trying to create this ecosystem, and I think they'll struggle, and it's going to take them a lot of years to do that if they're even successful. Again, the omic and the phenotype, combining that together is big. Sentiment analysis, which we looked at as well. And just on the takeaways on all of this is that really, and what I'm trying to do is tell you, don't buy into a framework that it doesn't allow you to move around, and don't buy into a SQL-based framework with a bunch of apps on it that you have to go back to the vendor to get another app created. This needs to be a self-service tool that you can be nimble with your staff and with your customer, your users, and work together using that company's tool set. Some of it could be open source, some of it not. To bring those solutions to your customer. And as you can see, the way this is going with healthcare, it's very things are moving at a very fast pace. And if you lock yourself into a framework, you're going to be stuck in that framework and ultimately not be happy. Machine learning will lead, and eventually there'll be artificial intelligence that'll be adapted to healthcare. You can see it coming. It's in other industries right now. It will be here as well. Something called get used to source now, ask questions later. It's really about, if you do have a nimble environment, it's just, bring the data in or access the data and start using it. And, we're no longer at a point in time, point-in-time construct any longer. Things are rapidly changing. Within a patient in a room, within a half hour, a lot of things could be happening to that particular patient. And if you're stuck in a framework that is not nimble enough, you're not going to be able to deal with that 30 minutes of that particular patient. So again, that's what I mean by it's not a point-in-time construct any longer. Again, get used to working with constant change. Your SQL people have trouble with that. Disruptive trends, something new that would make your frameworks obsolete. It could, some of the things we're building and some of the things I showed you, I can guarantee you, if I had a picture of our ecosystem in 6 months, it's probably going to look different than what I just showed you today. But you need to build that framework to be able to be adaptable and be able to change like that without costing a lot of money or throwing out one vendor and buying another vendor, those types of things, which I think you're going to see going forward with some of the stuff that's happening today. And just getting to your people, your existing skill set, it's incomplete. Everybody has SQL people, but you need data scientists. You're going to be doing distributed computing, cloud, need people to understand that, Hadoop plus, data visualization tools. And also, I think you're going to have on your team, cognitive and behavioral psychology people. I think that's going to be really important when you look at, facial recognition expressions and, some of these tools that are coming out that allows you to different ways to interact with patients. You're going to want somebody who has that kind of psychological background, on your team as well, helping you, design these systems. So again, you don't see SQL on here, and those people will be nervous, and mine are as well. But once they see the future and see, we'll give them the tools and the training so they can move forward, they get very excited about this kind of stuff. But again, you're going to have to look at your people and look at your organization as you build out your ecosystem and make sure you have the right resources. So I think that's it. So I'm going to throw it back to Anthony.
Very good. Thank you, Chuck. Incredible presentation. Lots of stuff to talk about. So we'll put you on hold until the Q&A, and we're going to bring in Mike House, who is the Senior Product Director with Optum. So, Mike, thanks so much for being a part and sponsoring this event today.
Thank you, Anthony, and thanks, Chuck. That was a great presentation, and I couldn't have said that stuff better than you did. I loved every moment of it. Good afternoon, everybody. For those of you that are not familiar with Optum, real quick, we are the product and services branch of the United Health Group, which itself is a Fortune, or number 14 actually, on the Fortune 500 list this year. And the other half of the UHG triad is United Healthcare, who is probably the largest benefits insurance provider, not only in the United States, but perhaps worldwide. And what's Optum's interest in data? Well, one of our missions is to enable United Healthcare to make optimal use of the data it has on over 70 million members. So that's a daunting task on a day-to-day basis. Real quickly, in this slide, Chuck used the greatest word I can come up with, which is ecosystem. The ecosystem that IT is a part of now has grown by leaps and bounds over the last 15, 20 years, which 20 years ago is a millennium and a lifetime ago. But to simplify it, back in the day, data processing, who cared about IT? The back office. Now it's everybody, inside and outside the organization. And Chuck's characterization as an ecosystem couldn't be more spot on. And to give you a real quick anecdotal example of the expectations that have emerged from this around something that Chuck talked about, the EMR. 10 years ago, I'm in the doctor's office with my son, and the doctor hands me a paper prescription instead of using the electronic prescribing capabilities. And my son says to me, why won't he use that? Why didn't he do that? Fast forward 10 years, and my girlfriend comes home the other day and says, hey, when are you guys going to get it so I can log into one portal and get to all of my providers? And I just added on the end, oh, and I suppose on your phone too, right? Well, yeah, of course. So, the challenges have done nothing but gone up over the years. And again, I don't want to elaborate on that point. Chuck articulated it very well. So this is a very elegant slide by Gartner, used by their permission, but it's a more detailed version of what many of you have probably seen, and that is the pressure on IT to provide more and more value to all the stakeholders in the ecosystem has gone up and up and up and up. And Gartner surmises, that IT only provides value about 32 cents on the dollar, with the rest of the dollar being spent on what's typically known as keeping the lights on. And Chuck alluded to the power of cloud computing in the data context, but we'll take it one step further. We at Optum firmly believe that the future of IT is cloud computing, as is now spoken of in the marketplace as hybrid IT or bimodal functioning, whereas Chuck alluded to the old way. Well, the old way is what's referred to as mode 1, and the new way, or the cloud-based way, is what is referred to as mode 2. And we at Optum are moving all of our products, goods, and services to the right, if you will. We're jumping into the cloud. And we can't say enough about how transformative cloud computing is to a business, those that are capable of and do take advantage of it. And my personal analogy is, some revolutionary things that happened in IT over the last 5 to 10 years. Think about 10 years ago when virtualization first came on the scene, and you virtualized servers. And the next thing you know, you virtualized desktops, and then you virtualized storage. Well, now, with cloud computing and the hybrid IT model, you can virtualize your entire data center. And so I think that's where we're going to start to realize the capabilities that Chuck alluded to that are necessary in the data enablement and data management and analytics space. and we're also going to achieve the cost benefits that we all seek on a day-to-day basis. And just to finish up real quickly, that's at the core of our Connect IT strategy, and I couldn't say it any better. This sort of sums up Optum's mission statement and what we try to live every day. Thanks, Anthony.
Very good, Michael. Thank you so much, and thanks to Optum for sponsoring today's event. Well, now we have a few minutes for Q&A. So I want to encourage everyone to send a question into the Q&A box, leave it in the lower right-hand corner of your screen, and leave the default set to all panelists. So let me start with a question, Chuck, from one of your colleagues. Everyone is interested in working on similar things. How do we take advantage of the specific work each organization is doing to expedite efforts instead of working in parallel silos? Chuck?
Yeah, that's a great question. You know, if you look at the maturity of you know, what we're trying to create here, we're very much on the immature side of that particular scale. There's no, you know, user group that you can go to, and you know, every vendor has a user group. You can go and get the latest and greatest for EHRs and for your particular vendor, but there's nothing out there really. I mean, there's seminars and things like that, but there's no user group that you can go to where everybody's kind of sharing best practices on a regular basis, because we're all, there's no cookbook on this stuff and no roadmap, so we're all kind of cobbling things together the best that we can based on the information that we have. So what I would offer, in just speaking for UCI, is anybody who wants to contact me, you got my contact information. You want to, you know, fly out here to Orange County, which, you know, might be nice to do in December or January, and visit us, and we can show you what we're working on. Happy to do that. Do it in a WebEx as well. But great question. I don't think there's really any way to do that today. We should probably think about how to figure that out. But again, I can offer, at least if you were interested in, you know, what I showed you today and you want to take a deeper dive on it, feel free to contact me, and you know, we can set up a trip or you know, other types of technologies to take a deeper dive in what we're doing.
Very good. Next question. With the smart notices for patients, how are you collecting the data that will help push these out? Is it data from the portal or EHR, which would include clinician-entered data, or both?
Both. Yeah, and you're also, you know, if you think about that Centriforce data, you know what their insurance is. Say we were in New York and it was a Medicaid patient, and you had access to that data in real time, and you can see how they use their smartphone and things like that, and how they want to be communicated to. You can start to blend that type of information into your patient interactions as well. So it's not just the EMR and the data that you have on premise. You know, it's the other types of data. If you think about that wheel that you're trying to build around that patient persona, you know, everybody that comes into your organization, wouldn't it be great to have that patient persona for each one of those individual patients, that wheel in place, that you could individualize your patient interaction to that particular wheel and what they're interested in. So I would take it beyond, you know, just the EMR and the other data sources that are, you know, traditionally being interfaced into those types of systems.
Mike, I want to bring you in here. You heard Chuck's bold prediction about SQL. He talked about the ecosystem and the limitations on SQL in his vision for the ecosystem of today and for the future. I just want to get your thoughts around that.
I agree wholeheartedly. We are actively, as I alluded to when I spoke, we are actively building a data enablement capability to offer to a broad ecosystem, a plug and play, if you will. One of the key aspects of taking on analytics challenges such as those that UC Irvine has, and Chuck alluded to it, is not only cost, but the ability to flex. Chuck alluded to, you know, you have storage limitations, and oftentimes you end up buying too much storage. If you have it on-prem, you're not using it all the time, et cetera. And the demands on analytics and data, you know, come and go. And again, the cloud allows you, especially that hybrid model, to flex your resources as necessary to answer the questions that you're trying to answer through your data and analytics efforts.
Very good. Chuck, any final thoughts? It's our last question. Any final thoughts on your prediction and to your fellow CIOs out there about whether or not they want to change any course they're on right now?
Yeah, I think, it's early enough on. I know a lot of, people are trying to make decisions around, do you just stick with your EHR vendor and for this type of ecosystem and they'll figure it out in the next few years? Do you try to build something on your own? Or do you, buy some of the commercially available products out there that, that claim that, they can do, everything in the population health space? And for the ones who've made those selections, it's, I think in a couple of years, you're going to be disappointed in those particular selections. For the ones who haven't made this selection, this is time to really sit back and think about your strategy and what your ecosystem needs to look like. And to me, this is not a replacement. It's really, you're pulling in, and it's not totally a single product either. It could be a single company that's pulling in, these data sources from all these different places. But again, it's something that needs to be nimble, and it's a variety of products that are cobbled together. If you think about how an app is developed, nobody develops an app from scratch anymore. You don't build all the components out of an app. If you need a search tool that's part of an app, you go and license to Google and pull that in. If you need GIS data, you go and license and pull that in. You don't build a search engine within your app. And that's really what you got to start thinking about here is building an ecosystem where you can pull from the the open source tools that are out there, and rather than just buying a product off the shelf, thinking it's like an EHR and it's going to solve all your problems in the data analytics world. And I think if you do that, you're going to be very disappointed. Maybe not day one, but 2 years out you will be, and then you'll be behind the gun of you spent a lot of money, probably multi-millions, and now you got to backtrack and do something different. So now's the time to really sit down and think about that. So if you want to strategize on that, feel free, again, like I said, contact me. You want to fly out here and sit down with my team and talk about it with your team. Happy to do that, before you make decisions.
Very good. Well, what a wonderful presentation. Lots of great information, lots to think about. I want to thank our featured speaker, Chuck Podesta, for joining us again. I want to thank Mike House for joining us and Optum for sponsoring. As I mentioned, you'll receive an email when our archive recording has been posted to YouTube. For those who hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU. If you've asked us to let CHIME know of your attendance, we will. If not, be sure you let them know. Sponsorship opportunities, contact Nancy Wilcox. General questions and comments, you can contact me. And you can go to our website to view our upcoming schedule. So once again, I want to thank Chuck, Mike, all our attendees, and everybody have a wonderful day. Thank you.